In the landscape of aging and oncology, early cancer detection remains one of the most critical yet elusive goals, particularly in older adults, whose risk of malignancy increases with every passing year. One emerging frontier in this effort lies in the realm of autophagy, the cell's internal housekeeping mechanism that maintains homeostasis by clearing damaged components. As we age, autophagy becomes progressively dysregulated, leading not only to cellular decline, but also to increased cancer susceptibility. This very dysfunction, however, opens a new diagnostic window. By tracking autophagy-related biomarkers, researchers are beginning to identify potential tools for early cancer detection, especially in elderly populations where conventional screening often falls short or arrives too late. Autophagy operates through a tightly coordinated cascade of molecular events: initiation, vesicle formation, cargo sequestration, and lysosomal degradation. Each step is governed by specific proteins, many of which can be measured in tissue samples, blood, or other biofluids. Key autophagy-related biomarkers include LC3, microtubule-associated protein 1A/1B, light chain 3, P62/SQSDM1, Beclin-1, ATG5, and ULK1. Their expression levels, post-translational modifications, and patterns of accumulation offer insight into whether autophagy is active, blocked, or dysfunctional. In early cancer development, these markers often change in predictable ways. For instance, P62, a cargo adapter that normally gets degraded during autophagy, accumulates when the pathway is impaired. This buildup can indicate autophagy blockage, which is frequently seen in precancerous or early-stage cancerous cells. Conversely, elevated LC3-2 levels may reflect increased autophagosome formation, which can occur either due to heightened autophagy flux or a bottleneck at the degradation stage. Discerning between these scenarios requires context, but in the right hands, they can serve as early red flags. Beclin-1, a key initiator of autophagy, is another notable biomarker. Its expression is often reduced in breast, ovarian, and prostate cancers, and its downregulation may precede full-blown tumorigenesis. In aged tissues, a gradual decline in Beclin-1 is common, but when this decline becomes pronounced or regionally specific, e.g., in colonic mucosa, breast tissue, or lymphatic organs, it may signal localized cancer risk. Combining Beclin-1 data with imaging or genetic risk profiling could thus improve early identification of malignancy in high-risk older individuals. The appeal of autophagy biomarkers for elderly cancer detection is twofold. First, they reflect the underlying biology of aging, a key driver of cancer, and second, they may offer earlier molecular signals than traditional methods, such as imaging or symptom-based diagnosis. In many solid tumors, especially in older patients, the cancer has often been growing silently for years before detection. By that point, treatment options are limited or less effective. If autophagy dysfunction can be reliably detected in preclinical or early cancer states, we gain a precious opportunity for timely intervention. Yet, several challenges remain. Autophagy is highly dynamic and context-dependent. A single biomarker measurement, especially in isolation, may not reflect the full picture. For instance, increased LC3-2 could mean autophagy is hyperactive or stalled at the lysosome phase. Only through paired measurements, e.g., LC3-2 with P62, or functional assays of autophagic flux, can a more accurate interpretation emerge. Furthermore, baseline levels of these markers vary widely between tissues, individuals, and even within the same person as they age. Standardizing reference ranges for elderly populations, who naturally experience fluctuations in autophagy, will be essential to making these markers clinically useful. Moreover, cancer itself can manipulate autophagy in different ways at different stages. In early tumorigenesis, autophagy suppression promotes DNA damage and instability, aiding cancer initiation. But in advanced tumors, autophagy is often reactivated to help cancer cells survive hypoxia, nutrient deprivation, and therapy. This duality complicates interpretation. Does a rise in autophagy-related proteins suggest healthy clearance of damage or malignant adaptation? Despite these complexities, there is momentum toward integrating autophagy markers into broader early detection strategies. Emerging studies are evaluating panels of autophagy-related proteins in blood tests for early detection of pancreatic, colorectal, and breast cancers. Some research suggests combining autophagy markers with aging-related inflammatory markers, e.g., IL-6, CRP, or senescence indicators, e.g., S-galactosidase, P16-INK4A may enhance diagnostic precision in elderly cohorts. The convergence of these pathways, autophagy, inflammation, and senescence, reflects the shared root biology of aging and cancer and may offer a multidimensional screening tool in the near future. In conclusion, autophagy-related biomarkers represent a promising but complex avenue for early cancer detection in the elderly. They offer a molecular window into the aging cell's integrity and response to stress, two critical factors in carcinogenesis. While no single marker is yet ready for prime time, a composite view, guided by systems biology and paired with age-specific baseline data, could form the basis of more sensitive, earlier cancer screening. In a demographic where cancer is often discovered too late, the ability to track cellular health through autophagy may one day allow us to intervene earlier, treat more effectively, and preserve quality of life well into old age.